All right. My name is Breanne Jacobs. I work in multiple hospitals in the DC area, in the community, and in academics. And I found that hospice in the ED has varied drastically depending on the health system that you're in. And I think that we have a lot of opportunities for education for this, for the residents and our faculty. So I sought out some experts in the field to talk to us today about hospice. So welcome to the presentation, Demystifying Hospice, a streamlined approach for referring patients with critical illness.
I'm Rita Manfredi from George Washington University.
I'm Dan Mark Walter from University of North Carolina, hospice and palliative medicine trained.
Hi, I'm Bruce Gutierrez. I'm a faculty member in emergency medicine and palliative care at Weill Cornell in New York.
Naomi George, emergency medicine, critical care, University of New Mexico.
Thank you. And I'm from GW as well. Nice. Thank you for coming today. We have no disclosures to share.
So today we just want to take some time to talk about how we can identify patients who come into the ED with serious illness and how we can identify who would benefit from hospice. We also want to give you some pointers on how to have these discussions regarding hospice with patients and their families. And we also want to talk about the current education in hospice for emergency medicine residents.
Can I ask a question on here? How many people know all of this already? Are any of you, like, I know Karen knows a lot of it, so we have some people that want to know new stuff, and you know a lot about it already. How about? You're a learner. You're a learner, and we have learners. Okay, good. So we have some good information we can impart.
And again, we do want to make this conversational.
Yeah.
Please feel free to interrupt us at any point, especially we have such a wonderfully intimate group.
Thank you. Okay. So we're going to start with a case. This is working your shift in the ER, and you have been told, oh, that room 6 has a new patient, go see him. And this is 76-year-old Mr. George Johnson. He's a frequent flyer to the ED. He comes in with shortness of breath. And he sees you, says, "Doctor, I'm just exhausted. I'm sick of getting poked and prodded. I never want to be on that machine again. All my life is about breathing. I need to take medicine to help me breathe almost every 2 hours. The medicine works, but I just feel like I'm getting worse, and I need more and more help every day, but I'm so sick of doctors and hospitals." So we're gonna...
Okay, so we're going to do this audience participation style. I wish we didn't actually know who was a learner, because then people are going to know. So the true false question. No, it's okay. It's okay. I learned a lot of this in the past 2 or 3 years. Because hospice and palliative really, they're under one umbrella, but there's major differences, and they're not just academic, right? Like there's practice differences, there's differences in rules, et cetera. So in order to enter hospice, you must have a prognosis of 6 months or less. True, raise your hand. False, raise your hand. Okay, you must have a prognosis of 6 months or less is true. Having a prognosis of 6 months or less and living 6 months or less are 2 different concepts, right? You may live for 6 days, you may live for 6 hours, you may live for 6 years, and you can recertify for hospice. But someone has to look at you. The person generally has to be a physician, and they need to qualify you for the hospice benefit by saying, I believe this person has 6 months or less.
So, some people confuse hospice and palliative care. And in fact, some emergency physicians think that palliative only has to do with end of life or death, right? Maybe many of your colleagues think that. So I'd like to dispel that for most people in the room. Just want you to know that palliative care focuses on the quality of life in seriously ill patients. What kind of patients do you see in the emergency department? Seriously ill patients. And so that's who we're focusing on. Hospice and palliative care focus on relieving suffering, relieving something called total pain. Anybody in the audience ever heard of total pain? Tell me what it is. Or tell the audience, what is total pain?
A combination of physical, psychological, social, and spiritual.
Right. Bio, psycho, social, spiritual. That's what we do that's different in palliative medicine compared to regular medicine. In regular emergency medicine, what are we all focused on? We're just focused on the biological. Palliative should be the way every doctor practices, biopsychosocial. So let's look at this more closely then. Up on the screen, you see that palliative is the umbrella of everything. Hospice is only a small part. So palliative care suggests and focuses on aggressive symptom management. So a lot of people in the hospital think palliative means giving up, we're not going to do anything. Look at that word aggressive. It's aggressive symptom management of serious illness, as well as serious illness discussions, and you know those as goals of care discussions. Hospice care, on the other hand, is a very small part of palliative, a very small part, but it's the comfort care at the end of life, which excludes all curative care. There's no curative there. So, in the ED, emergency physicians set the trajectory of all these seriously ill patients for their course through the hospital by what we do and don't do in the emergency department. So we set the trajectory. And unless we discover what matters most to our patients, we may do something to them that they may not like. And that's where these rapid goals of care discussions should be initiated in the emergency department. And that was part of what, it's interesting, our researcher just walked in who did worked with Karita Grudson to do the PRIME ER study, and that's what they did. They taught emergency physicians how to do these rapid goals of care in the emergency department. Okay. So, sometimes you might walk through the emergency department and look at patients, and you actually ask yourself, you actually ask the surprise question, and you may not even know you're asking the surprise question. Anybody who doesn't know about the surprise question, would you take a gander at what you think the surprise question is? Anybody know? Okay, Karen, what's the surprise question?
So we actually now have it when you put in an order into the computer in Epic, every patient that's admitted, it pops up the surprise question.
No kidding.
Said, would you be surprised if this, I wanted it to be, would you be surprised if this patient died during this admission? But you know what happened? That actually the EMS folks in my department got concerned, the people who think about resuscitations, they thought that that if we said, no, we would not be surprised, but then we weren't aggressive and the patient died, we'd get sued. So they had to change it to 6 months. 6 months. Would you be surprised if the patient died? But tons of people have done that question.
Right, so would you be surprised?
But I wanted to do, would you be surprised if this patient
Right,
died during this admission?
Yeah,
But
so
anyway.
would you be surprised if this patient's died within the next 6 months? So you as an emergency physician in the ED, that's a great place for you to start. If you walk by and you see somebody say, I wouldn't be surprised if that patient died within the next 6 months. That's a real good place to start, to say, maybe I should consider a hospice for this patient and go to the next steps.
So in ours, the pale care, you don't have to make a pale care referral, but if you say, no, I would not be surprised, it says, consider putting in either geriatrics or a pale care consult.
Oh, wow.
Wow,
That's
awesome.
great. That's great. That's on Epic, huh?
Yeah, right on Epic, we got Epic to do that.
So, in the emergency department, as an emergency physician, you do have to know a little bit about hospice because the families may ask you, you know, what do I do? What is hospice? Well, it's, and I know this is like preaching to the choir, but for those of you in the audience who might not know this, hospice is not a place. It's an insurance benefit. It's a type of care that's furnished by the interdisciplinary team. And so who's your interdisciplinary team? You have a hospice medical doctor, you have a hospice nurse, you have a chaplain, you have a social worker, and sometimes you have a home health aide that will come when the hospice team comes to your home where most hospice is practiced to take care of the family as well as the patient, okay? It's not 24/7 custodial care. And that's one real important thing that the people that don't know about hospice, you need to let the families know because there's this great misconception out there. And hospice also provides for durable medical equipment. Well, what's durable medical equipment? Beds, commodes, chairs, walkers, pads, cream or ointments for skin that might be subject to incontinence. But the big thing about hospice is no further hospitalization. And it's a lot of support for the patient and the family. If there is a hospice emergency at home, the family has been told, please call the hospice agency first. So this is what happens. Family calls the hospice agency, the nurse says, oh, I can be there in 30 minutes to an hour. What does the family then do? The family panics. And who do they call? No, they don't call Ghostbusters. They call 911. And so that's how you get those hospice patients in your emergency department.
Mr. Johnson, our case earlier, everyone's gonna have to vote, so get your hand raising hand ready. He must agree to DNR DNI to be enrolled in hospice. True. False. So I saw a few trues and a few falses. The answer is false. You do not have to agree to be a DNR or DNI to enter hospice. This is a tremendous source of misconception for not just, for formulaically who is eligible for the benefit, who isn't, whatever, but really sort of existentially, clinicians have a really hard time understanding how can you be on hospice and not be a DNR or DNI. It's about control, right? This is their patient autonomy is still the preeminent sort of principle that we all operate by. If someone doesn't want to be a DNR or DNI, they don't have to. In reality, a lot of hospice agencies may use several different soft methods to try to secure that DNR or DNI so that they're not trying to code someone in inpatient hospice in their homes. That being said, it's not a requirement of the hospice benefit. Patients shouldn't be strong-armed into it. And this only holds if they're getting a Medicare-approved hospice, and there are non-Medicare approved hospices out there also that your patients may come in from.
Yeah. And I would add that I think if I'm having this conversation in the ER with folks, I often find myself making a recommendation for DNR, DNI, but to that point, it doesn't mean that they have to accept that recommendation. And just like any goals of care conversation, these things play out over time. It's a conversation that's frequently brought up as someone's healthcare progresses with a hospice agency. I've been involved in those discussions with home hospice patients, and often their goals change over time. And so, to not let it be a
process.
Yeah, it's a process, and to not let it be a sticking point for getting somebody into hospice.
I guess my question would be, if hospice means no further hospitalization, how do you resuscitate somebody without hospitalizing them?
Well, so sometimes hospice patients are hospitalized for a reason that may not be directly related to their illness, their hospice qualifying illness. They fall and break their arm, or sometimes because, they have lung cancer and the hemoptysis was not controllable at home and the family doesn't know what to do. So they definitely end up in the hospital at different times, but they also could be in sites of care where they receive resuscitation. That's not the hospital, right? EMS might come, hospice nurse might be there, they may be at a nursing home receiving hospice, and it's theoretically possible that they may receive resuscitation. I'm sure it happens sometimes.
Yeah.
Well, and I would just add to that, as a hospice medical director, is that a lot of times you get someone to agree to hospice, but they're kind of still struggling with the whole code status thing. And typically, as a hospice, we will then work with the family and the goal is to get them to DNR over time. But yeah, you're right, it's not ideal, and it's not something we want to do, but you get them on a hospice and then you just let the hospice deal with it and they figure it out.
And frankly, most people who are starting hospice are DNR, DNI. I don't have the numbers, but
Yeah, and a lot of it may be an education issue, right? What does it even mean? I'm not confident that most patients know what DNR or not DNR means. Yeah.
I mean, there's still a lot of misconceptions of what DNR means in general. Some patients see it as like, oh, do not treat. So there's a lot of that misconception you also have to address. So a lot of it is just continuing those goals of care discussions, a lot of re-education, a lot of sort of reframing what DNR and DNI is.
And some doctors think that DNR means do not treat either,
Or do not send to the
hospitals.
MICU.
Yeah. Right, don't send to the MICU.
Well, a lot of things we talk about as I'm on the hospital ethics committee is sort of is the assent that, it's that great palliative care conversation of aligning the patient's goals with the hospice goals and saying, well, what I'm hearing you say is that you don't want any more intervention, and saying, would it be okay if I just put do not resuscitate, because that is in line with your goals. And so it's the having the really good conversation. and not always just starting right off with, do you not want, is it okay if I write DNR? Because that, again, they see that as do not treat, and it's more just sort of, sometimes it's like a passive assent, saying, this is in line with your goals, is that okay? And then they say yes, and then you can, it doesn't always have to be.
Oh, I was just going to say that I think there's some good literature in EMS about looking at pulse, where the top says, okay, I want CPR or I don't want CPR, as in, do I have a pulse or do I not? If I don't have a pulse, don't resuscitate me, right? Don't do CPR, so I am in DNR. But then section B says, well, if I have a pulse but I'm not breathing really well, yeah, do resuscitate me. I want to be intubated, or I want CPAP, or I want, And so this can be very confusing, not only for EMS, but for EM, and even on into the hospital. It's like, well, how can you want full resuscitation but be a DNR? Well, you have to get into nuances, right? So.
And you all from the ED may have to educate, right? I'm regularly telling my ICU residents, yes, they can come. They may have a DNR, they can come.
Yay, thank you, Nina.
And so, please, you can educate from the first floor, the ground floor.
So who qualifies a hospice patient? So this is not an all-inclusive list, but these are some of the common hospice qualifying diagnoses that we have. So it includes heart failure, obviously cancer, advanced dementia with complications. So what are these complications? Things like aspiration pneumonia, sacral ulcers. Like how many times have we seen the same 90-year-old nursing home patient who comes in for a 10th admission for the aspiration pneumonia, right? So these are patients that you may not necessarily think of, like your traditional, metastatic cancer patients who may qualify for hospice. So if you're seeing a lot of these patients over and over in the emergency room, and they have a lot of frequency admissions, really consider them hospice. And as Rita was mentioning earlier, if you just ask yourself, you look at the patient and you ask yourself, would I be surprised this patient died within the next 6 months? If the answer is no, then they're probably a good hospice candidate.
Sorry, yes, true or false? Hospice, home hospice provides 24/7 care. All for true, raise your hands. All for false, raise your hands. So I wrote the answer is false. I actually want to say it's probably more gray than that. You have 24/7 access to potentially. You potentially have 24/7 access to a resource. What that may look like probably depends on your environment. Are you rural? Are you close by? Your hospice agency, the resources they have. But is someone there 24/7? No, they're not. Family is there.
You look like you had a question.
No, more like, I was just like, what kind of care is this question asking about?
So, perfect,
Good,
yeah.
good plan.
Very good.
Yeah. And so, like we mentioned earlier, hospice is not a place. It is a philosophy of care. It can take place in different settings, right? So the most common one we think of is home hospice. And we brought up that question because a lot of patients and families think that if you go to home hospice, you get this 24/7 care. And so when you're talking to patients and families about hospice care or home hospice, because they want to be at home, we have to really emphasize that the majority of that care is going to be provided by either family members or privately hired caregivers. So the hospice agency does not provide 24/7 in-person care. So it really, so that your patient who you think may be appropriate for hospice, even though they want to stay at home, but if they don't have the resources and support to stay at home, then home hospice may not be a reasonable option for them. So that's one thing to really keep in mind. There is care, you do have access to 24/7 care to hospice, right? So that means is you have a 24/7 hotline. So if you have any uncontrolled symptoms, you can always call somebody, and someone's always reachable. Usually the type of care that they provide at home hospice is about 5 to 7 hours per week, depending on your level of symptom burden and how much care you really need. The goal is to really keep the patients as comfortable as possible with oral or sublingual medications. And there are some hospice agencies that, depending on the place that you work at, can also help PCAs. Which is a really great thing, right? If you can't manage your symptoms with just oral medications. And yeah, so that's home hospice. And then sort of on the other end of the spectrum. Next slide, is inpatient hospice. Yes, go ahead.
What was the same day admission?
Yeah, so I didn't want to really, this is very uncommon, and I'm gonna let maybe Bria and
Well, and
Rhea
it's,
talk
it's
more about
uncommon
this.
in some place, this is the
Yeah,
thing I
in
see.
some
So in my
places.
community shop in Virginia,
Yeah,
which is
Yeah.
very,
Yeah.
we have Capital Care and Hospice, and we have a nurse that's she put her card up in the ED, and I call her and I'll say, Becky, will you come in and talk to this family? And she is able to come in and talk to the family, and we have gotten people from the ED enrolled into home hospice and home that same day. There's other, 30 miles away in the city in DC, hospice is never discussed in the ED, and I don't know why. It's such vastly different hospice care in such a small geographic region, and I feel like that's the way it is across the country, and that's, so it is possible if you can get a really good hospice unit or caring organization that's affiliated with your hospital. Sir, please, add in.
I think one thing that might drive that is onboarding. So I think if you've got, when I was working full-time emergency medicine, I'd sometimes call down the University of Michigan and they say, we have 80 patients sitting in the ER, but we can't accept it no matter what it is. Those people are those institutions are very acceptable about real-time enrollment onto hospice because they're able to get somebody out. But, when I finished my fellowship, I went to my program director. I said, give me some primers to talk to hospitals about, doing palliative medicine and embedding it in the ER. He said, first thing you say is don't say you'll reduce admissions. The hospital doesn't want to hear that, right?
Yeah.
So if things are really working well and they're able to get patients upstairs, it may, that may be driving that. But we don't want them just, sent home from the ER because, hey, we can obs them overnight and get some revenue. So I hate to say that drives it a lot of times, but frequently it does.
Yeah, and so like, the geographic variation is very real in regards to this, I think. It depends on the hospice agencies geographically, so like, admittedly, this slide comes from my slide deck, so in Chapel Hill, North Carolina, we're able to frequently get same-day hospice admissions at home, depending on the time of day. But because we have numerous agencies available to us, both UNC's agency and multiple regional home hospice agencies, that if not the same day, then we can find somebody like the next day, and we can still get somebody discharged home, either for hospice to meet them at home or the next day. And we just discharge them with like a comfort pack of medications just to bridge them to the agency to come the next day.
I still think there is a utility to make these hospice referrals, even if they don't go home from the ED, because you're at least starting the enrollment process,
Yes.
right? And like you just said, instead of keeping them for, if they get admitted, instead of them staying for another 2 or 3 days to sort of set this up. But if you already started the process in the ED and, they were able to set up, home services by the next day, then you just reduce that patient's length of stay significantly, right? So I think
And we
there's
would say it
definitely still-
underscore the potential success of their hospice placement, because one of the biggest things that happens is not only are they shifting from, their Medicare to their hospice benefit, they are switching philosophies too. And to get symptom management titrated, to get family educated on board, that may not be a 4-hour project, right? That might be a 2 or 3 day project. You're working on having a hospital bed put in the first floor. You're doing all these things so that you can launch successful, if the patient wants it home, right? Like the number of people who are set up for home hospice in 3 hours is low. And so you can actually increase success of home hospice by taking that time in an obs admission or a boarded patient or, whatever it might be.
Yeah, the same day admissions from the ER are usually like those, was that?
You're already sick. and-
Yeah, you're either already sick and they're like, I just want to be at home, don't want to be admitted, and we try to do it. Or they're actually the fairly functional patient who's starting hospice, who can like walk out of your ER and go home, and they don't need a hospital bed right then and there. They don't need, they got fairly minimal needs, so that, it's kind of the
I'm interested in your guys' experience in this, but my lived experience is that people don't give hospice a second chance in the same way. They're like, what, I will go back to that emergency department even though I had a terrible visit last night. With hospice, it seems like they're like, nope, and it extends even beyond the patient to like the family. The family's also like, well, you can't do hospice. So I'm very biased, like hospice, you should go when you are ready, like in the line, like in work, to avoid people who are like, don't try to get.
And that's the frustrating thing, because there's so many hospice agencies, there's, Naomi said, there's Medicare approved ones and not, and then, so they vary in their level of responsiveness and care, and that is very frustrating as a doctor. Sir.
I like that in that what I've had trouble sometimes is when we'll do a hospice referral, is it's more an informational visit. But that you get an agency that's really hungry for the patients, and they're kind of a bull in a china shop. And they kind of go in there and say, sign up, and we're gonna get you enrolled in hospice, and everybody's like backpedaling, going, wait a minute. So I always like to kind of say, what prior experience do you have? You know, and kind of set that up.
Yeah, I think that's one is, I was trying to figure out what the experience was, which I'm sure you probably do some of that work as well. I'm flat out with people, I'm like, you know how you just told me that you had a really bad experience at this other hospital, now you're here at my hospital? The exact same thing happens with hospice agencies, like one agency is not equivalent to another agency. And then, I'm sure you all seen this, there's been like a huge boom in like agencies wanting to have their liaisons come and talk to patients at the hospital. And so now I've actually posted like the liaisons for several of the local groups like in our ER, so that if someone wants to like have them come in, like someone from an agency come in and talk to them, I could be like, hey, you know, I could have somebody from the hospice agency come and talk to you about some of these questions to see if it would be the right fit for you. Because I can also have the conversation, but it might help to have a face from that organization come and talk to them a little bit about what it would be like to have enroll in a specific agency. So that doesn't always grease the wheels, but it's an option to have the hospice liaison come and talk to them too.
So speaking more from a family standpoint, my dad was in hospice for metastatic cancer, and I think one of the things that's really missing from the handoff and care is the culturally sensitive information of like, what does this mean to the family? That there's a lot of explanation and re-explanation that I had to do. My parents are monolingual language speakers, so having to explain like, what does this mean? No, you're not dying today, and like, why, who are these people coming into our home, and all of those things. And I think, although his oncologist was amazing, she did like a very brief, and I think just having that cultural sensitivity aspect of like, what does this mean, and where you are in the touch point of your care, and that sort of thing, I think could be a great area of growth for this, and also just with the ED training of like, how do you explain to people who may not be so familiar with this type of care? Not saying that just because.
That's a great point.
No, thank you for
Yeah,
that.
those are good points.
Yeah. So we should work on a talk for next year.
One of the
Thank you.
issues that, not assuming, but if it's Spanish speaking, auspicio can mean to some, in some cultures can mean a TB sanatorium. So we've had patients in LA who are like, what, you're gonna lock me up? Like, what, they think of it as a place. I don't understand. But there are a lot of agencies that you can find that, have certain language. Like in LA, we've got some that are Vietnamese, many that have Spanish-speaking staff, so you can ask for that. And just one other thing about the admission, and one big problem we have is that the median length of stay on hospice 20 years ago was 26 days. It's now 18 days. In LA, it's 12 days, median length of stay. So yeah, you guys, because you're in the ED, are gonna see the ones that are like, oh, I hated hospice and I came back. But there's so many people that we do sort of try a little harder earlier and get them onto hospice. I mean, you just have a really crappy experience if you spend 7 days on hospice or less, which a lot of patients do now, and you have a much better experience if you can at least be on for like 2 weeks, 3 weeks.
Thank you.
But then you're gonna see more bounce backs, more withdrawals, but, yeah.
I'm in the LA, Southern California area as well. We have a really great system with vendors, our inpatient hospice team, our palliative team. We have observation unit protocols for enrollment. When I walked in, I heard that we often see that the patient may not be around with us for more than 6 days. Oftentimes we're dealt with shock family because the care teams may be siloed and no one's really unifying that information. So we kind of tend to be the middle persons. And we've really struggled with that space, with getting families on board and enrolled. And we've kind of strategized towards, you mentioned Pulse, about having kind of the initial steps of like an ACP who transition to hospice from the emergency department. And can you guys have any advice on kind of how to navigate, what seems to be the place we're placed most often in the care pathways of these individuals?
So you're saying, your question is where do when you're initiating the conversation for the first time, what usually happens, or what's the care pathway, the trajectory for the patient?
The conversations, when they go well, they're
Right.
a great system for it. It's oftentimes, we're kind of in the gray zone. The family's kind of shocked that we're relaying this information. They're not ready to hear this. We want to at least lay the framework so this work continues. They may not be sick enough to stay in the hospital, they may not be, the family may not keep them. Navigating that space, I think, is almost more important than the ones that we get enrolled, because those ones, we've met our goal.
Yeah.
Continuing that work so the family's not suffering, the patient's not suffering, they're not coming back and forth to ERs and getting fragmented care, and really trying to make it a linear process from that touch point.
Karen, you want?
Yeah, I was going to say that, our oncologists actually make very few referrals to palliative care and hospice care, very few. So what I've trained people to do is early referral to palliative care, because we have an amazing palliative care team. And so I try to get those patients well upstream, get to know the palliative care folks very early on, 4 months before, their anticipated death, if it's a metastatic cancer patient or whatever. And then the palliative care team can have that series of conversations and get to know the patient and family over months before hospice is actually ideal or appropriate. But it is impossible for a lot of patients, for me to tell them, I'm worried the time is short, and make that hospice referral, and for them to come the same day. That's.
But what you can do is, and then Daniel, I think, has some good points too, is that what I do in the emergency department, especially if they're not ready, I prep them for what's coming. And I say, upstairs, they're going to talk to you about things that matter most to you and your loved one, so that they can figure out how to match that treatment plan with what matters most to you. And what they're going to ask you is, what gives your mom joy? What is she worried about? How does she cope? And they're going to ask you, what would be an unacceptable quality of life for your mom? So you don't have to answer any of those things now. But when people hear those things, it goes in and it percolates around, and then they think about it maybe 12, 15 hours later.
Yeah. Just a couple kind of popcorn thoughts. One, there's always value in starting the conversation. The sort of flip side of that coin is, and I think someone alluded to this earlier, like I believe in hospice care. I believe in, for the right patients, getting the hospice from the ER is important, but we should never be forcing patients into hospice. So if somebody's not in that frame of mind, I totally agree. That's not the space. We should not be ramming this down people's throats. And so some of this is a little system dependent. What I've started doing probably more in my practice is, if they're in the University of North Carolina system, even if they don't have a palliative care doctor, and honestly our palliative care clinic space is pretty limited right now, I directly I send an in-basket message to their oncologist or their PCP, and I say, hey, and I will even write an advanced care planning note from the ER, say, hey, we talked about X, Y, and Z, just want you to be aware of this conversation for you to continue it, and at least that handoff, I like to think helps. And yes, I have been probably that ER doctor who's done their most in North Carolina, not opposed, but I do those in the ER. Somebody to at least document a conversation that happened, because just like the COSAS conversation, these things play out over time. So I don't put the pressure on people to be like, oh man, I didn't get this patient to hospice. It needs to happen at the right time.
Yeah, that's exactly right. The referral to palliative is definitely in my playbook all the time.
Yeah.
That at least enshrining something that they go home and say, we had this conversation, they gave me this piece of paper, this is what we want to do going forward for
There's
their other
some
care
good
providers.
tools
It's
depending
really
on
important.
the sort of technological, cultural sort of framework of the patient and family. I think start visit with patients. I wish I said I arranged primary care follow-up for all my patients, but I'm targeted, right? Because I'm busy and I'm 15 patients behind and someone just died in the waiting room, etc. But this is the one I'll call the PCP. If you're not a system fancy enough to epic message, if you're too poor for palliative clinic, etc. This is the one I'll message. I'll say I started the conversation, here's my note. Or if they're technologically enabled, this is the Three Witches website. So there's a little thing, and you can just make your footprint and then watch it float downstream and see what happens.
And also, I think one thing that because I'm not palliative trained, but I at least putting the seat and documenting what they said, who is the decision maker, who was in the room with the patient, the phone number, what words did the patient use to see what stage of the decision-making process they're at and what stage of the decision-making process the family is at. So, and it does take time to do that good documentation, but also, and we talked, you may or may not know, you can get paid for it. It is a procedure having these conversations in the emergency department. So the good documentation is great for patient care, but it's also something that is very, it's a good use of your time. And it does give the hospital doctor something to go from. And sometimes they just need that bridge of saying, oh, I saw you talk to the ER doctor about some of your goals. Is it okay if we continue that conversation? I think that can at least help you. If you at least started it. And so at least I know if I don't get anywhere, at least I can document that we've got some basic stuff for the palliative care team who has more time sometimes to take it from there. Please, go ahead.
I was just going to comment that I think embedding palliative care clinicians in the ER is becoming more commonly looked at across the country. But if you don't have the manpower really to do that, I think there's data out there showing that triggers to palliative services inpatient from the ER can sometimes drive the culture down into the ER and then kind of start driving these conversations a little more. So.
Yeah. I want to just, I love the discussion.
Yeah,
Thank you
this is
so
really
much.
good.
I just want to make sure we get through these things and continue the discussion.
So we talked about home hospice. Thank you for all everyone's comments. Now, on the other end of the spectrum is inpatient hospice. And sort of imagine this as an intensive care for patients with really uncontrolled symptoms. So if you really can't manage your symptoms at home, either because they can't tolerate PO or their symptoms are just too severe and you need a lot of medication optimization, then a lot of times they would qualify for something called inpatient hospice. Most of the time, a lot of these medications will be IV and requires like continuous monitoring by nursing and by a palliative care physician. And really the goal is to, and depending on the prognosis of the patient, the goal is to stabilize their symptoms and hopefully they can go back to home hospice once their symptoms are under control. Now, however, a lot of times patients who have such severe symptoms end up, dying in inpatient hospice. That's a very common trajectory. That is one, sort of on the other spectrum of hospice care.
It's me. Emergency physicians, true or false, emergency physicians can determine if a patient is suitable for a hospice referral. True, all this is true. Perfect, you're like, I'm sitting at this talk, it's probably true. All right. And we got next slide.
Yeah.
We've talked about a lot of this, but just to kind of bring it home, I think really the goal of serious illness communication, any goals of care, hospice or otherwise, is we're seeking to identify to take what's going on medically with the patient and what the patient's preferences and values are and try to make a recommendation that aligns those two things. And so as we discussed, sometimes hospice is not in line with those patients' goals, like living as long as possible. Maybe you're not going to make a recommendation for hospice in the ER, but maybe you're having a conversation with them and you start hearing things that say, ooh, that philosophy kind of aligns with hospice care. I want to focus on being comfortable, being at home, seeing my family. And then it's appropriate to make a recommendation from there for hospice.
So this true, false, we've kind of talked about only palliative medicine physicians are trained to have discussions about hospice with patients. True, false. All right, I'm preaching to the choir on this one. And this is what I'm very passionate about, just being a kind of a general ER doc. I've loved learning from Rita's talks. She's done EM Talk and she's a trainer for EM Talk, just getting phrases to use with patients to help me in a rush in the ER when I'm trying to manage a bunch of different things, the great EM Talk or Vital Talk phrases that work. So some of these, one of my favorites is it all right if I make a recommendation? And this, usually I also incorporate with the DNR, DNI stuff. We don't ask people, what type of diabetes medication do you want to be on? Do you want to be on a glipizide? Do you want to be on insulin? We make a recommendation. And so if we say, based upon what you said to me in our evaluation, I'm worried your loved one is dying, and with intensive medical care, we can't change the trajectory. May I make a recommendation based upon what you've said to me? And I've never had a patient say, no, you can't make a recommendation. And I feel like oftentimes it's a load off rather than me asking them to make the decision. Do you want your DNR, DNI? Do you want to go to ICU? It's more like, given what you've told me, I would recommend that we move to comfort measures. Is that okay? And so much you get that positive assent from the patient. And I'll ask the nurse, do you agree that that patient and the family feel that I explained DNR, DNI, and making them DNR, DNI is what we talked about. And I've always had the nurses say, I agree. They didn't have to say, yes, I want DNR, DNI, no, I don't want DNR. But the recommendation and the positive assent, the nurses always felt like it was done well, and the family had understanding and agreed to what we talked about is within line the patient's goals. And I take pictures of these things and I keep them in my phone. So this is another talk, if the patient has cancer, because his cancer is causing this, we can't fix his cancer. I recommend switching our focus. It's again, we're not moving away from aggressive treatment. We're using aggressive symptom treatment. It's just a different type of treatment. We're gonna move to treatments that aren't gonna help them live longer, but it's gonna help them have more comfortable care. And then may I recommend hospice to you, or have you heard of hospice? More conversation. Again, I take a picture of this on my phone. I hear you talked about, like the gentleman that came in at the beginning. You're tired of being on the machine. You're tired of being out of the hospital. I hear what you're saying, that being in the hospital is not what you want. So I have this is an opportunity that we can provide where you can stay at home as long as possible. Have you heard of hospice care before? Or, we're going to move our focus to quality of life, keeping you comfortable, managing your pain, and giving you more time with your family. And that your family can continue to care for you. And so this is something that is in line with what hospice team can provide for you. Is this something we could talk about more, or something like this? So, all right.
Perfect. The end of this talk kind of shifts toward the education piece, which I think many of us are particularly passionate about. But so educational milestones exist for teaching palliative care and hospice in the ED. True? All right, false? Well, all right, it's true. So let's do it just like a whirlwind tour. This is just example studies. There's many more studies, but kind of the current state of EM education, at least over the last 10 years or so, there's been a lot of needs assessments, and the bottom line here is everyone feels like it's important, and lots of attempts to implement different methodologies. So some of that's through asynchronous learning. Some of that has been through simulation. But point being, people think it's important, and if you teach them how to do it, people get better at it. And so that's kind of where we were up until a few years ago, when I think many people in the room, we can go to the next slide, familiar with this milestones framework that came out, which actually, which yes, Karen's an author on, so I know you're familiar with this. And so you're welcome to read the paper, but really looking at 3 domains, and I'm always self-conscious talking about someone else's paper when they're in the room, but looking at provider skill sets, clinical recognition of hospice palliative medicine needs, and logistical understanding related to hospice and palliative medicine and ED. And frankly, a lot of that's what we're talking about right now, especially the end-of-life care and the hospice portion. So please take a look at this paper if you're looking for ways to sort of incorporate sort of educational milestones into especially resident training.
I think the biggest challenge, though, is that it's not, a lot of the skills are not in the model of emergency medicine such they're tested by ABEM, so you don't get buy-in from a lot of program directors.
All right.
Some buy-in.
Yes. Thank you for the next slide.
All right, Karen.
All right.
And that's been Tammy Quest. She
Yeah.
started trying to do this in 2000, whatever, 3 or 4.
Yeah. Some work started by some folks at Ohio State. They started looking at how the geriatrics and HPM competencies and milestone things that have been published in both geriatrics and palliative care mapped onto the ABEM model of care, and then for those who are really in the weeds, into the KSAs as well that ABEM has. Many of them mapped onto either the ABEM model or the KSAs, but notably things that did not map onto either one were specifically what we're talking about here in particular. So treating end-of-life symptoms, caring for imminently dying patients, and caring for patients under hospice care. If you're teaching a lot of the palliative care milestones, you are in a sense teaching to the ABEM guidelines, even if there's not a lot of testing on it, but specifically end-of-life care does not really pop up a lot in the ABEM model of care or KSAs. So that is, to Karen's point, a blind spot.
An area for opportunity.
Area for opportunity. Area for opportunity. And then finally, just lots of resources. We've already talked about several of these in various facets. CAPC has some good training, BioTalk, Epic. Justin Bruton has started the Pally-EM website with some podcasts and other resources, including some on-shift guides. So you can take a look at that. And then if you're going to read one article, many are probably familiar with the Anthony Freda article, but that is sort of the primary palliative care best practice guidelines for the ER. Some really great, concise summaries of how to do some of this work in the ER. So just leaving you with those. There's been some really good discussion already,
Thank
but
you
we
so
do want
much
to open it up for
for
other. Yeah.
other thoughts. I see so many of the people in this room are already champions for hospice, and my question for you is how do we get more interest from residents and other just ER doctors in your faculty that aren't palliative care trained to participate in the Vital Talk discussions or have these discussions? What successes have you had at your institutions in that regard? Please.
We have an institutional task force that's multidisciplinary on advanced care planning and hospice. Vital Talk is required for GME, so all residents take Vital Talk. Which is awesome.
All residents take
All
Vital
residents.
Talk.
Wow.
And it's getting re-upped this year. Actually, that meeting at 2 o'clock today. So
Where is
that's,
this?
part of
Where
the-
are you?
UC Irvine.
Okay.
Yeah, so.
Where do you get your money?
Yeah, that's
The first round was a grant that funded the Train the Trainers program. We're currently looking for second round funding. It's either going to come from individual departments. The GME comes from School of Medicine. So they've allocated in the budget as line items. But the departments are individually responsible for the Train the Trainers, and unfortunately ours moves on to advance their careers. So I think that's going to be my next step of work.
So I'm gonna make a plug for two things. One, I think COVID was instructive. Moral distress is the thing that the C-suite cares about because burnout and departure is where they're losing money, time, training, expertise. So your needs assessment around moral distress is something you can point to. The second thing I'll make a big plug for, because I sort of fell backwards into UNE, is that it is way cheaper to train medical students because we're not buying their time off the wards. If you train them as medical students, they then are residents who are trained. And this is how we've done it on a slightly smaller budget. They're not going to necessarily stay at your institution, but if we all kind of band together and say, no, we want them even further upstream, we want them either further eventually. And I've noticed doing UME for like 4 years now, the quality of the conversation is radically improved year by year. Their sophistication and cultural responsiveness, cultural humility, bringing some whatever to these conversations keeps moving forward. But that's sort of like what is it, the common green for prisoner's dilemma type thing. We all have to train our medical students for us all to get residents who are trained. I do have a question for the hospice palliative care folks from the non-educated standpoint. I don't know if we have time for it.
Please.
My question is around kickback laws. How do I become a champion and partner with local organizations who I need to support them to learn and understand, right? Like, can I make a hospice diagnosis as a non-HPM physician? We all said, yes, I can. The truth is, there's a lot of rules and regulations about what's going to qualify, so I almost always work with someone to be like, hey, hey, hospice medical director, I think we're here. I'm willing to say it. Like, are you going to accept this? Are you going to take this? Depending on their risk aversion, whatever, and the ones I know and trust they work with and I learn from. But then as I build those relationships and I see which hospice agencies aren't failing my patients and I see which ones are working, how do I then point towards those? Because I care about my patients and their outcome without running afoul of kickback laws.
Yeah, so that is what we're dealing with in LA right now, because there's like 800 hospices and a lot of them are actually not even real. I would say, so two things. One is you don't have to know if someone's hospice eligible to refer them. It's the hospice's job. It's not your job. So if it pops into your head, you think they're eligible, just refer them. And then if the hospice doesn't think so, then, or they take them on for 3 months and then they, might kick them off. If you have hospice, if you are completely allowed to recommend an agency, the way to do it is to say, do you have any agencies that you prefer? If not, would you like me to recommend some that I've worked with that I think are sound, especially ones that do physician visits, that have hospice medicine physicians. As long as you are not getting money from that agency to refer patients, you're not breaking the law.
Okay.
And as long as you offer them options, you are not breaking the law.
Yeah.
But people don't understand, like the VA, I'm now not allowed to recommend. And I have had my social worker call an agency that I refer to, that I have been recommending, and ask them, oh, is Dr. Emer, does she work for you? Because she wanted to sort of catch me out. And I'm like, no. I mean, yeah, if you're taking money from agencies to refer, then you're breaking the law.
So, so you're sort of, as you start that conversation with, hey, do you have an idea? And most people don't have an experience or an idea of what you can see they want to work with, and then to use that pool of experiences to point.
And I think there's some state level differences with regard to this. Like David, when he told me that in California, you can't make specific recommendations.
You can.
You can.
You can, but it's not true. You have to ask the patient, you know, do you have preferences? And you can offer them, but I mean, most of the time, there's like 4 or 5, 6 that like you think are good.
Right.
And there's 890 that are crappy.
Yeah.
And like, I would worry, like, we have kind of a special relationship with one hospice in our town. And so even if I'm not making money, there is this kind of weird interchange between the hospice and the hospital. So I'd also be sure that you're not like only
Right,
referring
for
that.
smaller environments.
It's really hard for us because there are 90% market dominance in our town. So like, it's very likely small up there.
Yeah. So I mean, so long as there's choice, and like, so I know we had to go, like we're in an interesting situation in my institution because we have our hospital, but UNC also has its own hospice, and so they're very big on making sure that we provide people choice because we don't want to get in trouble about this. But also UNC Hospice is the only hospice home around that will do a compassionate extubation, and so sometimes we have to tell, like, we have to phrase it kind of as a recommendation, like we have a way to have your loved one extubated outside the hospital if that's important to you. It would be through our hospice agency, but letting them know that there are other ways that there are other pathways that they could go. So it's a way of like making a recommendation, but you have to still have some choice in that. But sometimes there's not really a choice. If they were like, we want to do an extubation outside of the hospital, then that's the only option.
Thank you so
Yeah.
much. Thank you for coming to the discussion.
Yeah.
We can
Thanks,
stay around after.
everybody.
Thank you.
Thanks for all your insights.